Hello everyone. Today I am going to cover the newborn examination. So learning objectives are how to take the newborn history, how to examine the newborn baby, and what are the various neonatal terminologies and definitions, and how to make the probable diagnosis. So today I will cover the newborn history taking part. This is the chronological order to take the newborn history. First, we have to take the basic information, then chief complaints and history of present illness, then family, then maternal history, then previous obstetrical history, then history of this pregnancy or antenatal history, then labor or delivery history, or we can say natal history, then postnatal or neonatal history, then feeding history, then immunization history. So these are the 10 points we should write in chronological order. In basic information, we have to write mother's name, age, date of birth of the baby, gestation age by last menstrual period, birth weight of the baby, and address and mobile number. In chief complaints, we have to write down the presenting complaints with duration in chronological order. Example, if coming with the complaint of vomiting and fever, and vomiting since last 4 days and fever since last 5 days, then we will write down the fever first since last 5 days, then vomiting since last 4 days. Common chief complaints in neonatal history we find feeding difficulties, vomiting, then we have to differentiate vomiting and regurgitation. Failure to pass stool, we should know that normally baby pass stool in 24 hours. So parents are not aware about this, so they are generally coming with this complaint also. Baby is already having the 6 hours of life, is still not past the stool, so we have to counsel and reassure them. Failure to pass urine in 48 hours, it is also a very common complaint. Then again we have to counsel them that normally newborn pass urine in 48 hours. So after 48 hours we have to do the intervention. Before 48 hours it is the normal physiological range for the pass of urine. Then sometime constipation and loose stool. Again we have to reassure them because newborn babies are having the different GI transit time. So sometimes they pass the stool once in a week. It is also normal. And sometimes 10 to 12 times in a day. It is also the normal. But we have to differentiate either it is the normal physiological or is it pathological. So for loose stool, we have to differentiate, is it the gastrocolic reflex or is it the neonatal diarrhea? I will tell you in next slide how to differentiate the common physiological findings with the pathological. Yellow discoloration of skin, because we know physiological jaundice present in 60% of normal healthy term babies and 80% of preterm babies. Hiccups, sneezing, yawning. Sometimes parents are coming with these complaints also. So this is the normal finding. And fever, skin rashes can be there. So we have to differentiate what is the etiology of fever and skin rashes, either physiological, as I have discussed in the previous neonatal skin disorder slide. Various benign neonatal conditions are also there. Sometimes parents are coming with the complaint of excessive crying. So we have to differentiate, is it the normal cry or excessive cry. So whenever baby is crying for more than 3 hours continuously, not consolable, then we label the excessive crying. Otherwise, baby normally cry whenever hungry or pass urine or stool, or whenever there is a environmental temperature is not comfortable for the baby. Eye discharge, again common in newborn period, either because of conjunctivitis or because of nasolacrimal duct blockage. In first 2 to 3 weeks, of life, newborn is not having any tear. So whenever there is a watering or secretion from eyes, we have to suspect either conjunctivitis or NLD blockage. Excessive sleepiness is again a common complaint by the parents. So we have to explain them that newborn babies sleep for 18 hours normally, hardly wake for 6 hours, only for feed after every 2 hours and whenever pass urine and stool. Vaginal bleeding and secretions are common in female newborn baby because of maternal hormone in first week of life. So again we have to reassure them. Scalp swelling, asymmetrical head shape is again the common complaint. I will tell you in detail in next video. Congenital deformities are also common in newborn. So we have to first examine and according to the different deformity we have to give the treatment or advice. After ODP we have to take the history of present illness. So just take the example of vomiting. So first we have to write down the onset. Onset is acute, subacute or chronic. Then we have to write down the duration of vomiting, since how many days. Then progression, is it non-progressive or progressive? Example, if baby is having vomiting since last 3 days, then since onset baby is having 2 or 3 episodes in a day, then we will say it is non-progressive. If on first day hardly 2 episodes and third day patient is having 7 or 8 episodes, that means it is progressive. Then write down the frequency of vomiting, then associated with nausea or not. Then about the vomitus, its color, content, is it bile stained or even the fecal matter is present. Example, in intestinal obstruction, we have to differentiate the what is the level of obstruction by these points. Then interval between vomiting and given feeds will give us the clue about the etiology. Then also see the activity and look after vomiting. So we will be able to differentiate, is it regurgitation or actually vomiting. So regurgitation is the passage of gastric content into the oral cavity and sometime out of the mouth. It is a physiological condition present in newborn period and generally persists up to 4 months of age. Very rarely, in very few patients, it can even persist up to 2 years of age. Vomiting is the forceful expulsion of the gastric content through the mouth. And in vomiting, we know there is an intense muscular activity of the respiratory and abdominal muscle, and it is centrally mediated somatic reflex response. And vomiting is always pathological. Clinically, we can differentiate regurgitation and vomiting. In regurgitation, baby is healthy, looking well, and gaining weight normally. While in the vomiting, there will be sick look, baby will not gain the appropriate weight, so we can differentiate. Now take the another example, loose stool. So again we have to ask the onset, duration, progression, then frequency in a day, then associated with the abdominal distension or not, we have to write. Then about the stool color, consistency, is it blood or mucus stained, we have to ask. Then interval between the feed and passing stool. So it is again we have to differentiate gastrocolic reflex from neonatal diarrhea. So in gastrocolic reflex, which is a physiological finding, whenever mother will give the feed to the baby spontaneously, either during the feed or at the end of feed, baby will pass the stool. So when milk will be entered into the gastric stomach, this reflex will start and colonic movement will start and baby will pass the stool. Then also ask the urine output is adequate or not, because we know normally newborn should pass the 6 to 8 times urine in a day. So whenever with the loose stool urine output is less, that means baby is having the neonatal diarrhea, and this is the sign of dehydration. And also check the weight gain with loose stool. So again, we have to differentiate, is it the gastrocolic reflex or neonatal diarrhea? So gastrocolic reflex is a physiological reflex, and in this colon is stimulated immediately in response to the stretch of stomach with every feed. Increased motility is there. So it is around 10 to 12 times in a day. So whenever mother will give the feed, baby will pass his stool. This condition also persists up to 4 months of age. It is physiological. Now in the neonatal diarrhea, baby will have the watery, very loose stool. There is a no relation with the feed, and baby will have the crying due to the cramping with the diarrhea. So pain abdomen will be there. Again, clinically we have to differentiate. In gastrocolic reflex, baby will look healthy, well, normal urine output will be there. There will be no sign of dehydration and appropriate weight gain will occur. While in the neonatal diarrhea, sick look, decreased urine output, signs of dehydration, baby will not gain the weight. So this is also asked in the Viva how to differentiate physiological and pathological conditions. Then in family history, we have to write down the age of parent at marriage, then history of consanguinity, then is it nuclear or joint family, number of family members, siblings. Then we have to draw the pedigree chart. Then about the chronic illness and inherited disorder in family member, we have to show in pedigree chart. Then history of contact should be asked about the tuberculosis. These are the symbols in pedigree chart. Example for male, this is square, female, circle, and this is for marriage. If carrier for any inherited disorder, then we have to draw like this. For unknown sex, this is the symbol. So these are the various symbols for various different uh, family conditions. After taking the family history, we have to take the socio-economic history, in which we have to ask the occupation of family head, and other family members are also doing some work, then we have to write down. Then we have to calculate the income of all the family members, then education of family head and other family members, then housing condition, is it kacha or pakka house, the number of the person living in one room should be asked. So various diseases are common with the overcrowding. Type of water for the drinking and cooking. Then we have to calculate the per capita income, in which total income of the family divided by number of family members. Then we have to calculate the SES by the modified Kopuswamy socio-economic scale, in which we have to give the score according to the education, occupation, and monthly income of the family. So according to the score, we have to categorize either upper middle, lower middle, or upper lower or lower. If a score are less than 5, we consider lower SES. If between 26 to 29, then upper SES. Now after family history and SES, we have to write down the maternal history, in which we have to write down the mother's age, weight, height, any chronic maternal disease if present, then about the treatment for this condition. Example, mother is suffering from hypothyroidism, then about the thyroxine we have to write down. Then mental health of the mother, substance use, alcohol, tobacco, anything mother is consuming. Then about the maternal and paternal genetic history, we have to write. After that, we have to write the previous obstetric history, in which GPA, G stands for gravidity. So total number of confirmed pregnancy is G. Example, if a mother is having G5, means 5 times she is pregnant. G5. Then we have to ask about the parity, number of infants that are alive and dead, we have to write. So example, if mother is having uh, 2 live baby and 2 expire, so we will write the 2 plus Two live plus two dead babies. Death of the two babies has occurred. So in bracket we will write down the total four babies. One abortion also there. So we will write down A1. So total number of pregnancy she had 5. Two live baby she is having and two expired and one abortion. So we have to write down GPA, and then again we have to ask about the cause of death, age at the death, and also we have to ask about the birth weight of the previous infant, any problem with the previous infants, neonatal jaundice, preterm delivery, congenital anomaly, we have to ask. So this is the way to write down the obstetric history. After the obstetric history, we have to write down the antenatal history. We can divide the antenatal history into first, second, and third trimester. So in first trimester, we have to write down last menstrual period, antenatal checkups were done or not, then hemoglobin and blood group of the mother, any history of fever and rashes, and any post-auricular lymphadenopathy during the first trimester because it suggests the torch group of infection. So if baby is having the IUGR with hepatosplenomegaly, then we have to ask this history. It is occurred in the first trimester or not. Then about the exposure to drugs, radiation, any addiction, or about the folic acid supplements. In second trimester, we have to ask mother failed the quickening or not, and about the TT injection, at least 2 doses received during the pregnancy. Then iron folic acid tablets were continued. In second trimester, folic acid tablet ideally should be started 1 month before conceiving and should be continued. And iron should be started in second trimester. Then about the USG done during the second trimester also, and what was the finding? And mother is having any illness, example PIH, diabetes, hypothyroidism, or any infection, HIV, HPS, which is going to affect the baby. We have to ask the history. And any bleeding or leaking PV present during the second trimester, we have to note down. And antenatal checkups, how many times taken during second trimester. Then in third trimester, how much weight gained by the mother. We know mother generally gain the 10 to 11 kilogram throughout the pregnancy, and most of the weight gain occur in third trimester. So we have to ask how much weight gained by the mother and supplements were continued or not. Then again we have to ask any bleeding during the third trimester, any infection, illness, and USG was done or not. We have to ask in USG any polyhydramnios or oligohydramnios or any congenital malformation was mentioned or absolutely normal. Any history of drug intake, exposure, or radiation. After antenatal history, we have to take the natal history, in which we have to mention either baby is term, preterm, or postterm, hospital delivery or at home delivery was take place. Then mode of delivery, either LSCS. If LSCS, then also write down the indication, or normal vaginal delivery or assisted vaginal delivery. Then we have to ask baby cried immediately after birth or not. If not cried, then we have to label birth asphyxia. Baby passed meconium or not, we have to ask any resuscitation was done at the time of birth, any history of prolongation of labor, also mention the birth weight, and also we have to mention breastfeeding was started immediately within half hour of birth, or if not, then at what time of life, how many hours after birth breastfeeding was given to the baby. After natal history, you have to mention postnatal history. So if the baby is having any significant problem during the neonatal period after birth, we have to mention in the postnatal history. So any feeding problems or any other feed before starting the breastfeeding label as a prelactal feeds given to the baby or not. Baby has passed urine or stool timely within 48 and 24 hours respectively. And when the umbilical cord fell down, if the baby is coming after 7 to 10 days of life, then umbilical cord will not be there, then you have to ask. Baby was admitted in NICU for any complication, example for jaundice or any convulsion or any other issues. Then we have to mention in detail in postnatal history. Otherwise, we can mention postnatal history was non-eventful and not significant. After that, we have to take the feeding history. So we have to ask about the breastfeeding started within half hour of birth or not, especially in normal delivery, and in LSCS as early as possible breastfeeding should be started. And baby was on exclusive breastfeeding or any prelactal feeds were given before starting the breastfeeding. We have to mention. Then we have to ask some relevance point to assess the adequacy of breast milk. Whenever there is a adequate breast milk, baby will be satisfied for 2 hours and baby will take the adequate sleep of 2 hours after feeds. And baby will pass the 6 to 8 times urine in a day. And also there will be a weight gain 10 gram per kilogram per day. So these things we have to assess and ask to assess the adequacy of breast milk. If baby is not on breast milk, then either giving the katori spoon feeds or giving the feeds with the nifty cup or giving the feeds with the pellidi. So we have to ask, this is the nifty cup. It is a silicone based cup and its capacity of 40 ml and also having the small uh, rectangular reservoir and showed depth 2 to 3 ml here. And this is katori spoon and this is pellidi. So here in this video you can see they are giving the katori spoons feed. If baby is not on breastfeeding, then you have to ask about type of milk mother is giving, either express breast milk or infant milk formula or cow, buffalo or goat milk. Then how much quantity of the milk giving in 24 hours. Then how much dilution. Sometimes mother is taking 100 ml cow milk and diluting with a 100 ml water. So we will mention 1:1. So also mention the dilution. Then you have to calculate the calories and protein present, what is expected and how much deficit is there in feeding history. Then take the immunization history, birth dose of BCG, OPV and hepatitis B given at birth or not. Now second part, newborn examination, I will cover in next videos. Thank you so much.